A 71-year-old man named Walter came to me 16 months ago. He had been a secondary school mathematics teacher for 38 years. Methodical, logical. A man who approached every problem the way he had approached every equation in his career, with patience, with systematic reasoning, and with complete confidence in his ability to identify what was relevant and what was not. His daughter had brought him in, not because he was alarmed, because Walter had been feeling dizzy. Not dramatically, not the spinning room vertigo that sends people to accident and emergency departments. A quieter dizziness. A subtle lightheadedness that arrived most mornings when he stood up from his chair. A brief graying of the edges of his vision that lasted 5 to 10 seconds and then resolved completely. He had been experiencing it for 11 months. 11 months of standing up, steadying himself against the nearest surface, waiting for the sensation to pass, and then getting on with his day. He had mentioned it once to his GP, who had told him to rise more slowly and stay hydrated. He had been rising more slowly and staying hydrated. The dizziness had continued. His daughter had noticed him grab the kitchen counter one morning. She had noticed the slight pause before he took his first step after standing. She had noticed that he never mentioned it anymore, not because it had gone, but because he had accepted it. He had accepted it so completely that he had given it a name in his own mind that required no further investigation. He called it one of those things that happens after 60. One of those things you simply learn to manage. When I reviewed Walter's full clinical picture, his blood pressure taken lying down was 138/84. Reasonable. Managed. His blood pressure taken 60 seconds after standing was 97/61. A systolic drop of 41 points within 1 minute of rising. His heart was working. His medication list was doing something it was not supposed to do. And the dizziness that he had accepted as one of those things was a measurable, documented, clinically significant cardiovascular event occurring multiple times every single day. It had a name: orthostatic hypotension. And it had consequences that Walter had come very close to discovering the hard way before his daughter brought him through my door. I'm Dr. Kevin Adjuel. I'm a cardiothoracic surgeon. I spent over 30 years operating on hearts, repairing arteries, and sitting across from patients who have normalized something their body was never designed to normalize. What I'm about to share with you, most doctors won't bring up at your annual checkup, but after 60, it matters more than you think. Today, I am going to talk about a specific feeling, a feeling that millions of adults over 60 experience regularly and have accepted as a normal part of aging. That is, in many cases, a serious physiological red flag. I'm going to explain exactly what it is, what is happening inside the cardiovascular system when it occurs, why it is so consistently accepted rather than investigated, what the real consequences are when it goes unaddressed, and exactly what to do if you recognize it in yourself or someone you care about. Stay with me. Because what I'm about to describe is happening in the homes of people who feel fine, people who have simply stopped noticing that fine and genuinely fine are no longer the same thing. Before I name the feeling, I need you to understand something about the cardiovascular system after 60 that most people have never been told. Because without this understanding, the feeling I'm about to describe will seem too minor to be worth the book attention I am giving it. With it, the significance becomes immediately and uncomfortably clear. Think of it this way. Your cardiovascular system is not a passive plumbing network. It is an active, constantly adapting system that makes thousands of micro adjustments every hour of every day to maintain stable blood pressure across every change in your position, your activity level, your hydration status, and your emotional state when you stand up from a seated or lying position. Approximately 300 to 800 milliliters of blood, nearly a full liter, shifts downward under gravity into the vessels of the legs and abdomen. That shift happens in seconds. And in those same seconds, The cardiovascular system must respond with a precisely coordinated reflex to prevent your blood pressure from collapsing and your brain from losing its blood supply. That reflex involves three simultaneous responses. The heart rate increases, the blood vessels in the peripheral circulation constrict to push blood back toward the core, and the blood pressure is maintained at a level sufficient to keep the brain adequately perfused despite the gravitational redistribution. In a young, healthy cardiovascular system, this entire reflex arc is completed in 1 to 2 seconds. The person stands, the reflex fires, blood pressure is maintained, no dizziness, no pause. No steadying hand on the nearest surface, it happens faster than conscious awareness. After 60, that reflex slows. The baroreceptors, the pressure sensors in the aortic arch and the carotid sinus that detect the drop in blood pressure and trigger the compensatory response, become less sensitive. The heart rate response becomes slower and less precisely calibrated. The blood vessel's ability to constrict rapidly becomes less reliable as arterial walls stiffen with age. And the kidneys maintain a lower resting blood volume as they become less efficient at regulating fluid balance. The result is that the same gravitational blood shift that was handled invisibly at 40 now takes longer to compensate for, and during that compensation delay, blood pressure drops, sometimes modestly, sometimes significantly. And the brain, which has almost no reserve capacity for reduced blood flow, registers that drop immediately as lightheadedness, as brief visual dimming, as a floating sensation, as a momentary unsteadiness that most people interpret as dizziness. That is the feeling, that lightheadedness when you stand, that brief graying at the edges of the vision, that steadying hand on the wall, that moment before you take your first step. That is orthostatic hypotension. And it is not one of those things. It is a cardiovascular event that occurs every single time it happens. And in the bodies of adults over 60, it carries consequences that the word dizziness does not begin to adequately convey. Here is why this is dismissed so universally. The experience is brief. It resolves spontaneously. It does not prevent the person from doing what they were about to do. And it occurs so regularly, multiple times a day, for some people, that the brain habituates to it. The thing that frightened the person the first few times they experienced it becomes background noise within weeks. They stop registering it as a warning. They start registering it as Tuesday. This habituation is one of the most effective ways that a genuine physiological problem can disguise itself as normality. Not because the problem has resolved, because the person has stopped noticing it enough to be concerned. But here is what nobody tells them about what that brief dizziness is actually doing each time it occurs. Here is what is actually happening inside the body. When blood pressure drops acutely upon standing, when the systolic falls by 20 millimeters of mercury or more, or the diastolic falls by 10 or more, within 3 minutes of rising, the brain experiences a transient reduction in cerebral perfusion. The brain receives less blood per second than it requires for full function. The gray out, the lightheadedness, the floating sensation, these are the conscious experience of cerebral hypoperfusion, of the brain running briefly on inadequate fuel. In most episodes, this lasts seconds and resolves as the compensatory reflex eventually catches up, but in those seconds, the brain is under genuine physiological stress. And here is what that repeated stress does over time. Research published in the journal Neurology followed a cohort of adults over 60 with documented orthostatic hypotension over a 25-year period. It found that those with significant orthostatic drops had a substantially higher rate of dementia, of silent cerebral infarction. Small areas of brain tissue death that produce no immediate symptoms but accumulate as cognitive damage and of clinical stroke compared to those without the condition. The brief dizziness was not benign. It was not something to manage with advice to rise more slowly. It was a recurrent cerebrovascular stressor whose cumulative effect on brain tissue was measurable across decades. 25 years of data, thousands of patients, A clear and consistent association between the feeling that Walter called one of those things and the outcomes that his daughter was afraid he was moving toward without knowing it. That is not the only consequence, not by a significant distance. The most immediate physical danger of orthostatic hypotension is falling, and I need you to understand the specific danger of falls in adults over 60 in terms that go beyond the obvious. It is not simply that falls cause fractures, though they do, and hip fractures in older adults carry a mortality rate of 20 to 30% within 12 months. It is that the fall occurs during a moment of cerebral hypoperfusion. The person does not simply trip. They experience a brief reduction in brain function that affects their reflexes, their spatial awareness, and their ability to protect themselves during the fall. The fall from orthostatic hypotension is therefore more dangerous than a mechanical fall, the kind that occurs when someone catches a foot on a rug because the protective responses that would normally reduce injury are simultaneously impaired by the same blood pressure drop that caused the fall. The brain and the body are both compromised at the same moment. The Centers for Disease Control and Prevention estimates that falls are the leading cause of both fatal and non-fatal injuries in adults over 65 in the United States. 1 in 4 adults over 65 falls each year. And orthostatic hypotension is independently identified as one of the most significant and modifiable risk factors for those falls. Modifiable. That word carries enormous weight here. Because if orthostatic hypotension is identified, its causes can be addressed, its severity can be reduced, and the fall risk it carries can be meaningfully decreased. But only if it is identified. Only if the dizziness that has been accepted as normal is recognized instead as the clinical signal it is. Here is what most people are never told about what causes orthostatic hypotension after 60. And this is where the story becomes specifically actionable. In the majority of older adults who experience it, orthostatic hypotension is not simply the inevitable result of aging. It is the result of aging combined with one or more of a specific and identifiable set of contributing factors, factors that are modifiable once they are recognized. The most common is medication. This is the piece that Walter's story illustrates most directly. A significant number of the medications most commonly prescribed to adults over 60 cause or worsen orthostatic hypotension. As a known and documented side effect, blood pressure medications, particularly alpha blockers like doxazosin, calcium channel blockers, ACE inhibitors, and diuretics, reduce circulating blood volume or blunt the vasoconstriction reflex in ways that make the positional blood pressure drop more severe and more prolonged. Antidepressants, particularly tricyclics and certain SSRIs, impair the autonomic reflexes that manage positional blood pressure. Alpha blockers used for prostate conditions in men have orthostatic hypotension as one of their most consistent effects, and combinations of these medications, which many older adults take simultaneously, can produce cumulative orthostatic effects that are significantly greater than any single drug alone. Here is what is actually happening inside the body when these medications contribute to orthostatic hypotension. Diuretics reduce the total circulating blood volume. There is simply less fluid in the vascular system to maintain pressure against the gravitational shift when standing. The compensatory reflex has less to work with. The drop is deeper and the recovery is slower. Alpha blockers prevent the vasoconstriction that is supposed to push blood back toward the core when standing. The peripheral vessels stay dilated. Blood pools in the legs, pressure falls. The brain is underperfused, and the person who stands up from their chair 3 times an hour to make tea and check the pulse is experiencing that physiological cascade 3 times an hour without knowing that the medication their cardiologist prescribed for their prostate or their blood pressure is the primary driver of the dizzy spell they have named. One of those things. Research from the British Journal of Clinical Pharmacology found that polypharmacy, the concurrent use of 5 or more medications, was independently associated with a 3-fold increase in the rate of clinically significant orthostatic hypertension in adults over 65 compared to those taking fewer medications. Threefold. And the most significant individual drug contributors were precisely the medications most commonly prescribed in this age group for the conditions most prevalent after 60. The second major contributing factor is dehydration. Adults over 60 have a reduced thirst drive compared to younger adults. The hypothalamic thirst mechanism becomes less sensitive with age. The kidneys become less efficient at conserving fluid, and many older adults deliberately restrict fluid intake to manage urinary urgency or incontinence, creating a state of chronic mild dehydration that reduces circulating blood volume and makes every positional blood pressure drop more severe. A body that is even mildly volume depleted has significantly less reserve to maintain blood pressure during the transition to standing. The dizziness is more pronounced. The recovery is slower, the fall risk is higher, and the solution in many cases is as straightforward as drinking adequately throughout the day. Not dramatically, consistently, 6 to 8 glasses of water spread across the waking hours. That simple adjustment in fluid management can produce a measurable improvement in orthostatic blood pressure stability within days. The third contributing factor is prolonged bed rest or physical inactivity. The orthostatic reflex, the entire cascade of baroreceptor activation, heart rate response, and vasoconstriction is maintained and strengthened by the repeated practice of standing. When an older adult spends extended periods sitting or lying down during illness, after surgery, or simply as a consequence of a more sedentary lifestyle, the reflexes involved in positional blood pressure management become deconditioned. The body becomes less practiced at the rapid cardiovascular adjustment that standing requires. Regular, gentle, progressive physical activity, specifically activities that involve repeated transitions from sitting to standing, helps rehabilitate those reflexes. It is not simply exercise for fitness. It is specific training for a cardiovascular reflex that degrades without use. Tell me in the comments, do you experience lightheadedness or a brief graying of vision when you stand up? Does it happen most mornings? Have you been managing it by rising more slowly and assuming it is simply age? Because I want to know how many people watching this video have given this feeling the name that Walter gave it, one of those things, and have not yet understood that there is a clinical investigation, a medication review, and potentially a treatment standing between them and the consequences that the feeling represents. That question matters. Your answer matters. The fourth contributing factor deserves specific attention because it is the one that is most frequently overlooked in the context of orthostatic hypotension and the one whose implications extend furthest: autonomic neuropathy. Damage to the autonomic nervous system, the network of nerves that controls the involuntary functions of the body, including heart rate, blood pressure regulation, digestion, and bladder function. Autonomic neuropathy is a known complication of type 2 diabetes, of vitamin B1-2 deficiency, of Parkinson's disease, and of several other conditions that are disproportionately prevalent in adults over 60. When the autonomic nerves controlling blood pressure regulation are damaged, the baroreceptor reflex is impaired, not because the baroreceptors themselves are less sensitive, but because the nerve signals from them cannot be conducted and acted upon with adequate speed and precision. The blood pressure drop on standing is more severe. The recovery is more prolonged. And the orthostatic hypotension may be accompanied by other subtle autonomic symptoms: constipation, bladder dysfunction, abnormal sweating, sexual dysfunction that together paint a picture of a more widespread autonomic dysfunction than simple age-related reflex slowing. In a person with diabetes who is experiencing regular lightheadedness on standing, autonomic neuropathy should be specifically considered and specifically tested for. Not assumed, not inferred, tested. The investigation is straightforward: a tilt table test or a series of autonomic function tests that assess heart rate variability and blood pressure response to various stimuli. These tests are available through cardiology and neurology departments, and they provide information about the integrity of the autonomic nervous system that cannot be inferred from a resting blood pressure or a routine blood panel. Here is what is actually happening inside the body in autonomic neuropathy-related orthostatic hypotension. The binaural receptors detect the pressure drop when the person stands. They fire their signal along the afferent autonomic nerves toward the brainstem. The brainstem processes the signal and fires the efferent response, the instruction to the heart to increase its rate and the instruction to the peripheral vessels to constrict. But in autonomic neuropathy, those efferent nerve fibers are damaged. The signal is weak. It is slow. It arrives at the heart and the blood vessels with reduced strength and reduced precision. The heart rate response is blunted. The vasoconstriction is incomplete. The blood pressure drop persists longer than it should, and the brain continues to be underperfused for the additional seconds it takes for the damaged nerves to complete what healthy nerves would have accomplished in one. Research from the American Diabetes Association confirmed that orthostatic hypotension secondary to autonomic neuropathy was present in approximately 30% of adults with long-standing type 2 diabetes, and that the majority of those individuals had not been formally diagnosed with the condition despite experiencing its primary symptom, lightheadedness on standing, on a daily basis. 30%. With no formal diagnosis, with no treatment, with no understanding of what the feeling meant or what it was doing to their brain and their fall risk, every day it went unaddressed. Let me give you the plan. Because everything I've described today is not a list of things to worry about. It is a map of things to address, and most of them are addressable. I call this the Orthostatic Protection Protocol, 5 specific steps beginning this week. Step 1. Measure your orthostatic blood pressure. This requires a blood pressure cuff, which every adult over 60 should have at home. And 2. Minutes. Take your blood pressure while sitting, then stand and take it again after 60 seconds. If the systolic has dropped by 20 or more, or the diastolic by 10 or more, that is clinically significant orthostatic hypotension. Write both numbers down and bring them to your next appointment, not described in words, measured numbers on paper. That documentation changes the nature of the clinical conversation. Immediately, step 2. Bring your complete medication list to your GP and request a specific review for medications that may be contributing to orthostatic hypotension. Name the condition. Do not describe the symptom and wait for the connection to be made. Say these exact words if helpful. I have been measuring my blood pressure sitting and standing, and I have a significant orthostatic drop. I would like to review whether any of my current medications are contributing to it. That sentence opens a conversation that may result in a dose adjustment, a medication switch, or a change in timing of medications that produces a meaningful and rapid improvement. Step 3. Assess and address your hydration. If you have been restricting fluids, if you drink fewer than 6 glasses of water a day, if you rely primarily on tea and coffee, which have diuretic effects, for your fluid intake, address this deliberately. Increase water intake gradually across the waking hours. Front-load your fluid intake in the morning when orthostatic drops are typically worst. Reduce fluid after 6 in the evening to manage nocturnal trips to the bathroom. This adjustment costs nothing and can produce measurable improvement in orthostatic blood pressure stability within a week. Step 4. Change the way you rise from sitting or lying, not simply more slowly, with a specific sequence. Before standing from a seated position, pump your feet and ankles in a circular motion 10 times. This activates the muscle pump in the calves, the mechanism that pushes venous blood from the legs back toward the heart before the standing transition adds gravity to the equation. Then stand slowly. Remain still for 10 seconds before taking your first step. That 10-second pause allows the orthostatic reflex to complete its work before you place demands on a blood pressure that may still be recovering. That sequence takes 30 seconds. For a person with significant orthostatic hypotension, it can be the difference between a dizzy spell and a fall. Step 5. Request formal evaluation if the episodes are frequent, severe, or associated with near fainting, with actual falls, or with the autonomic symptoms I described: bladder dysfunction, constipation, abnormal sweating. Blood pressure that varies dramatically across the day. Formal evaluation includes a tilt table test, autonomic function testing, and in some cases a 24-hour ambulatory blood pressure monitor to capture the blood pressure pattern across a full day and night. That evaluation provides information that a resting clinic measurement cannot. And it may identify a treatable underlying cause: autonomic neuropathy, medication toxicity, volume depletion, minus that changes the management plan entirely. I want to come back to Walter. After his blood pressure measurements were documented, lying, sitting, standing, at 60 seconds and at 3 minutes, his cardiologist reviewed his medication list with specific attention to orthostatic contribution. His alpha blocker for prostate symptoms was switched to an alternative with a significantly lower orthostatic profile. His antihypertensive dose was modestly reduced given his documented positional drops. He was given specific guidance on hydration and on the ankle pump technique before standing. He began a gentle walking program 3 times a week, 20 minutes, which also served as progressive conditioning of his orthostatic reflexes. 6 weeks later, his daughter called the practice to say he had stopped reaching for the counter when he stood up. He came back to see me 2 months after that. He sat down across from me, carefully, methodically, the way a mathematics teacher sits when he is about to make a point he has been constructing for some time. And then he said the thing that has stayed with me ever since. He said I had given that feeling a name that made it require no further thought. I called it age. I made it into something with no solution. And it turned out it had several. That is what normalized symptoms cost, not just health, the thinking that might have protected it. Let me say the key points one final time. The lightheadedness when you stand is not one of those things. It is a measurable drop in blood pressure that the brain experiences as cerebral hypoperfusion. Over years, that repeated hypoperfusion is associated with cognitive decline, silent cerebral infarction, and increased stroke risk. Each episode increases fall risk in a way that is compounded by the simultaneous impairment of the protective reflexes that should break the fall. The causes: medications, dehydration, physical deconditioning, autonomic neuropathy, are identifiable and in most cases modifiable. The investigation: sitting and standing, blood pressure measured at home with a cuff, takes 2 minutes and costs nothing. The conversation it opens with your doctor can change the trajectory of your cardiovascular and neurological health in ways that the feeling itself, normalized and named and filed away, never will. Which of these 4 contributing factors do you recognize in your own situation? Are you on medications that appear on the list I described? Are you managing your fluid intake around bladder symptoms? Have you been sedentary for an extended period? Tell me in the comments. I read every single one, because those answers tell me how many people are living with a normalized feeling that has a specific cause, a specific investigation, and a specific treatment, and have never been told that any of those 3 things exist. If this video gave you something that changes how you think about that morning dizziness, share it. Not for me. For the person in your life who has been calling it age, who has been reaching for the counter every morning for a year and assuming that is simply what mornings feel like now. Who does not know that 2 blood pressure measurements and 1 medication review could change what the rest of their day and the rest of their decade looks like? They may not know, but you do now. And that is exactly why you are here. And if you have not subscribed yet, please do. Every week, I bring you honest, evidence-based information that I wish every one of my patients had access to long before they needed surgery. Take care of your heart. It has been working for you every single minute of every single day without asking for anything in return. Give it what it needs. It is a fair trade. One last thing, and this is important. Everything I have shared today is general medical information based on published research and my clinical experience as a cardiac surgeon. It is not a substitute for your personal medical care. If you are experiencing frequent or severe episodes of dizziness, lightheadedness, or have had a fall, please speak to your own physician before making any changes to your medications or your daily routine. They know your history. They know your clinical picture. I do not. This is education. Use it as the beginning of that conversation. The conversation that Walter wishes someone had started with him 11 months earlier.